Good morning. My name is Ivor. I am one of the co-chairs, along with David Ross, of this Data for Health initiative, and I want to welcome you to Learning What Works for Charleston. So thank you for being here today. Thank you for rising early in the morning and spending time with us today to talk about Data for Health. I want to also recognize our advisory committee members who are here. If you could raise your hands and be recognized. Thank you. Thank you so much. Get to know those people. Please talk to them during the day. They want to hear from you, and we want to hear from you, so please do that. Just a reminder that we're live streaming today. This is the 5th and final listening session for our Data for Health initiative, and we've gone across the country. We've gone to Philadelphia, we've gone to Phoenix, we've gone to San Francisco, we've gone to Des Moines, and this has been a wonderful opportunity for us to really learn and go across the country and learn about how communities are using data for health, and really how they're using it to improve health. And the reason that we're here today is to really tap into your brain power and to understand more about how you're using data for health, and to really think today as futurist, to think about the future and how you want to use data for health in the future, and what we can do to prepare for that future where we're using data for health in a way that builds a culture of health for our communities across the country. I especially want to thank the Robert Wood Johnson Foundation for supporting this effort and bringing us all together today. And when they asked me to serve as co-chair along with Dave of the committee, the advisory committee, I said yes immediately. They were a little shocked. I was a little shocked because it meant going to 5 cities in a very short period of time. But the reason that I did that is because I really believe in the power of data for health. And the reason that I believe in that as a pediatrician and as a healthcare provider and as an academic and a researcher, I really understand what it means to use data in my work life, but I also understand the power of data in my personal life. And I'll give you a little bit of a background and why that's so important to me and why I came to value data. My father had a traumatic brain injury when I was 9 years old. And at that time, we didn't have health insurance, but he's a veteran. And so my father began his care and received his care in the VA system. And so he developed a seizure disorder, and he's had seizures since that time. And I went through medical school, I went through residency, and was a practicing physician, and didn't fully have an understanding, because we didn't call it a traumatic brain injury at that time. We didn't know. We just understood that he developed seizures at some point. And it wasn't until we got access to his data and his medical records through Blue Button that I really was able to comb through the information with my family, and for us to understand the origin of his seizure disorder and the fact that it was a traumatic brain injury that contributed to that. And we were able to interact and engage with his health team in a completely new and different way. Yes, now we could go to a different provider, but all of his data was there in the VA system. And my mom was happy there, he was happy there, so why should we change? And so we stayed, because we had data, we had information, and our providers and all of his providers were communicating with each other and sharing that information with each other. So I saw, for me personally, in addition to the work that I do, the power of data for me and my family to actively partner and engage with his healthcare system and the healthcare providers. So when they asked me to do this, I said yes. So I hope as you came into the room today that people followed the instructions. And there are some questions up on the screen. And the questions are, how have you used data to improve health in your community? What type of data would you love to use to improve people's health if it existed, you knew about it, or had access to it? And who would you like to collaborate with to improve health in your community? And I've talked. Now I'm going to stop a little bit and ask people who've answered those questions to please raise your hand and tell us where you're from, tell us a little bit about yourself, which question you answered and what your answer is. There are people in the audience with microphones. Anyone, don't be shy. We have someone over here.
I'm Shelley Quenga with the Palmetto Project. We're a statewide nonprofit. We use data to get money.
Yes. Anyone else?
This is question number 2. My name is Dave Zellner. I work for a nonprofit, Protection Advocacy People with Disabilities. If we knew more where people with disabilities, usually health-related, were located, we could better reach out to them. Rather than waiting for them to learn about us and call, we could be contacting them if we knew where they were, people with diabetes, people with traumatic brain injury.
Thank you. That's an excellent, excellent example.
Good morning. I'm Rick Foster. My day job is with the South Carolina Hospital Association, but I work with many different organizations. Here in the local community, I'm on the board of CHA, which is the Health Information Exchange with all the hospitals in the community, and so we're using that data to really look in a different way at specific populations at risk that are using emergency room services. At a state level, we're trying to work with our hospitals to help them look at data in a way that's more population focused, including from a disparity and equity standpoint as far as the utilization and quality data. And then finally, there's a new health coordinating council, which is a public-private partnership with senior leaders from 45 organizations in the state, and we're trying to use data in a way to set basically big dot goals to improve health at the population level for all of South Carolina.
Wow. I think those are just some examples of how we're harnessing data now and the power of data. Now we have one more. But then I also encourage people to think about how we're using it now, but how can we use it? How can we use it even more? How can we think big about the use of data for the future?
Hi, my name is Les Leonard. I'm from the Medical University of South Carolina and from Health Sciences South Carolina, a data organization for the state that is collecting data from the 4 of the leading hospital systems in the state and looks to expand to include all of them. I want to answer 2 questions, if that's okay. One, what type of data would we most like to have inside Health Sciences South Carolina to improve the value of that? We have hospital data coming into us live now from 4 of the leading chains, as I was saying, and that we'd like to have more. But what I think we really need is patient data. We need patient-reported outcomes. We need measures of health. And then secondly, who would you like to collaborate with in your community to improve health? And the answer is all of you. We would like to make Health Sciences South Carolina's data available as broadly as possible to the state, to provide data to not-for-profits, to provide data to researchers to drive their efforts. And that we have good interfaces for this, we have good procedures for making it available, and I'd like to start the day by inviting people to do that.
Thank you. One of the wonderful things about this is the people in the room who start making connections, and we're really excited about that. Thank you, and it's going to be a rich and valuable discussion today. For those of you who are following and using social media, we encourage you to tweet out at hashtag data4, that's the number 4 health, and it's at the top of your agenda. RWJ is going to be tweeting live. We also have a social media booth outside, and we encourage you to go out and speak about data for health and share your thoughts on data for health. And if you're not following at RWJ_live, please, please do. So next, I want to introduce Hilary Heishman. She's from the Robert Wood Johnson Foundation, and she's going to share the foundation's vision about building a culture of health. Thank you.
Good morning. Thanks, Ivor, for your welcoming comments this morning. You know, you and Dave Ross have been an ideal duo to lead us through these data for health listening sessions, both because of your expertise, but also because of the extraordinary commitment that you bring to improving health for all. I also want to show my appreciation to the rest of the advisors. The thoughtfulness that you've brought to this listening series has been really great. I feel fortunate to be here with you today in Charleston, South Carolina. It's pretty exciting. And I'm excited about the range of experiences and leaders that we have together in this room, because I'm eager to hear the insights and the innovative thinking that you're going to bring to this discussion of data for health. I would like to thank the Department of Health and Human Services for joining us here today. They too are going to be listening to what you have to say throughout the day. I'd like to thank the local planning partner. The South Carolina Institute of Medicine and Public Health has been very helpful in pulling this together today. Would you raise your hand for a second so folks can see where thank you. Thanks so much. I want to say a big thank you to the planning team who's participated in all 5 of, and helped plan all 5 of these listening sessions. So I have a couple colleagues from the Robert Wood Johnson Foundation. Please raise your hands. Thanks, guys. Thank you so much to the National Network of Public Health Institutes. Please raise your hands. Thank you. Thank you so much to the team from Virginia Tech. Go Hokies. Where are you guys? Thank you. And thank you so much to Burness Communications. Really, the folks I just mentioned have done so much work for this. I really appreciate you. So the mission of the Robert Wood Johnson Foundation is to improve health and health care of all Americans. And we've had the goals over the years to work on things like reducing childhood obesity and reducing smoking rates and improving the quality and value of health care. We've worked on addressing social and environmental influences of our health, where we live, learn, work, and play. And building on all of that past work, we recently have a new vision, and it is to build a culture of health. This is about making sure that everyone in the United States has the opportunity to live a healthier life, both today and for generations to come. So when I say culture of health, you might be wondering what we're talking about. It's not necessarily immediately obvious to everyone. So I kind of say, you know it when you see it. So for example, a culture of health looks like kids in schools having access to healthy, appealing food. And it looks like people lending a hand to each other in a community like this to prepare for a hurricane. And it looks like community leaders making decisions based on the option that's going to lead to the best well-being for residents. And it's going to look like businesses introducing new product lines because health sells. And it's going to look like going to the doctor's office hassle-free and then getting a warm, convenient handoff to the next doctor that you need to see. And it looks like older adults feeling safe and cared for. So you can see that this is an ambitious vision that we have, and clearly it's not something that the Robert Wood Johnson Foundation is going to do alone. It's going to take all of us. So data and information are important for building a culture of health. Think about it for just a second. Each day, each of us, we create all kinds of data. Where we work, when we go to the doctor's office, the gym, and educational settings, your phone, when you go shopping, and the organizations you work with, you have information about the community too, or access to different kinds of information. And when we're able to weave those together, take different pieces of data and put it together and weave it and build it into information, we're able to build a story about a group of people, about a population, and that story, built with data, built with information, becomes an important, powerful tool to building a culture of health. So I worked in a health department for a few years, and while I was there, we did a health assessment, and we gathered up all kinds of data about the community. And I was really excited to see the story that we could piece together about the community, the things that we could understand that we hadn't known before we started looking at that data. I was also frustrated by the fact that that story was sort of spotty and the ending wasn't clear. We didn't always know what to do with it, what it really meant, because data didn't exist or we didn't have access to it. So it sure looks like, to build a culture of health in this community and across the nation, that it means that we're going to have to figure out how to get better at safely and efficiently getting, using, and managing information on this path to building a culture of health. So a conversation about data for health, yes, it's about technology, but well beyond technology, it's about our own actions and our concerns and fears and our hopes. It's about our relationships between people and organizations and sectors. This is also a conversation about the guidelines and privacy and trust. And it becomes a conversation about strategy, too, when we're talking about data for health and building towards a culture of health. So that's why we're here today. We're here today to listen to you in Charleston, South Carolina, because we know we have a lot to learn from you. And we would also like to hear about what you hope, what you could do with data towards building a healthier community here. So we at the Robert Wood Johnson Foundation take great pride in being able to host an event like this, because we know that conversations like this, where people are able to be frank, and where people have genuine desire to make things better, we can plant seeds for change. So again, thank you for coming. Thank you to listening to me talk about a culture of health for just a few minutes, and we're really excited to hear what you have to say, what you have to share with us today.
Thank you, Hilary. Now it is my honor and my pleasure to introduce Dr. Karen DeSalvo. Karen is the Acting Assistant Secretary of Health at HHS and the National Coordinator for Health Information Technology. As National Coordinator, Karen is spearheading the charge to identify ways that health information it says here, can be adopted and meaningfully used at all levels of government. I have to say it.
Don't torture them.
And, but what I really want to say is that Karen is passionate about really how we can use data in a way that's meaningful, not just in healthcare, but in health, and thinking about it where we live, learn, work, and play, and how those things can come together and interact. And I'm going to let her talk about it because she can talk about it so much better than I can. So thank you, Karen. Good to see you.
She reads that bio, we'll be here all day. Well, good morning, everybody, and good morning, Charleston, which I got to say at 6:30 this morning on Good Morning Charleston, actually. So it's like the middle of the day for me already. I'm really thrilled to get to come here. It's actually my first trip to Charleston, and what I got to see a little bit of this morning, it's a beautiful city, and the few people that I've met have been really warm and generous, and I'm looking forward to today to learning more about what is happening here on the ground so that we can do a better job as a federal partner to meet you all where you are. The Office of the National Coordinator for Health Information Technology is an entity inside of Health and Human Services that has been serving the country for a decade now. It was started with the notion in mind that it was important to collect electronic health information, particularly about the healthcare experience for every American, and see that we could connect that care across the continuum in much the way that Ivor described for her father, that wherever he went, the health data was there to meet him, to make sure that good clinical decisions could be made and that he had his most convenient experience, seamless experience, and didn't have to get unnecessarily stuck twice for blood, for example. That work really picked up steam in 2009 when something called the HITECH Act came into being, and it was a part of the stimulus bill, and it put out a set of grant programs that helped to catalyze the marketplace to build infrastructure in states like South Carolina and help frontline providers, some 150,000 docs and hospitals across the country that have been touched by our programs like the Regional Extension Center, so that they not only have to get some help in deciding which product to select as an electronic health record, but when they take off the shrink wrap and turn on the computer, they have some technical assistance to actually make it work and make their workflows go better. There was also this big tranche of money, which we spent about $27 billion of, that as part of an incentive program through Medicare and Medicaid to offset the cost of adopting the electronic health record. It costs money to buy, it costs money in your workflow, and so the Congress set out a program that would allow that to be offset. All this in the last 5 years has meant that we have really accelerated the adoption of electronic health records in clinical practice on the front line. So now about more than 90% of hospitals have an electronic health record that they're using, and about 60% of doctors' offices that are part of the Meaningful Use program. So a really dramatic acceleration, because it was well around 15% when we started all this just back in 2009. So what does that mean, and why would we want to be here today about that? I'll tell you what it means is that we've had tremendous success as a country in the first tranche of bringing forward the digitization of your health experience. That we have been able to create a mass, I should say, a host of data that speaks to people's health care experience, that is sort of pushing at the doors and wanting to be freed. I can tell you the consumers want it to come out because you want it there when you arrive for care. But the world has also evolved in other ways in the last few years, and the rapid evolution of technology has meant that the notion that the electronic health record paints the picture of your health is no longer the right notion. The world has evolved in a way that the collection of data, as was described some already this morning, and as you know from your own personal experience, has dramatically evolved. What we call the health IT ecosystem is much broader than it was 5 to 10 years ago when ONC had these other major milestones. And so as we look to the future, as we at ONC take on our responsibility of setting the federal health IT strategic plan, what are we supposed to do on your behalf as the federal convener, bringing together the departments and agencies across the federal government to decide what's important for the country, how should we set priorities, where should we go? We're recognizing that the world has evolved, and the success of the collection of data in the front lines of healthcare has meant now there's something to be shared, something to follow people across the care continuum and beyond, something that can be aggregated into big data to tell a story about a community or about a population or about the public's health. And in fact, the increasing movement around something that I learned in Des Moines, a term I learned called long data. So some people would call it a longitudinal health record, but it's a way of following you across time with your health information and not just having a point of care. These are not just ideas. There are use cases that are in play right now. I know in South Carolina you're using data to tell stories about your communities and try to make evidence-based policy decisions. We know that healthcare institutions are doing the same thing. We also know that nationally there are a host of really big companies that are creating the sort of infrastructure of data that would allow your information to follow you over time and wrap around you in a more holistic way. And that data, by the way, is going to be much more than just what happens in your healthcare experience. It's kind of like saying that your financial health can be described only by your bank account, right? You all know that your financial picture is much broader than that. It has to do with set of assets and your income and your future earning potential and a whole host of other things that you know matter to you. So just in that same way, your electronic health information is a part of a larger picture. So as we're thinking about our planning for the next 5 years, we are looking to a way that we can create a policy framework, a supportive infrastructure that allows for health information to tell a picture of health well beyond just what happens in healthcare, health about where you live, learn, work, and play, using data that comes from sources well beyond the electronic health record and can tell a more holistic picture of folks' health, and understand not only what we need to do as the federal government with all of our levers, our purchasing power, our policy opportunities, but in partnership with the private sector. The enormity of the task ahead to see that we create a safe and secure and accountable data infrastructure that tells the picture of health for individuals and populations and our public's health is more than any one agency like ONC or a department like HHS can do. It is something that has to be done in partnership with the community. It has to be done in partnership with states, with the private sector, and where appropriate individuals. This is really about creating a person-centered plan and a person-centered approach. And so as we are listening and learning from these sessions, my team, raise your hands in the back from ONC, are here to listen and participate. This is the 5th of these that we've been able to weigh in on, listen in on, I should say, as you weigh into us. It is informing the way we're thinking about prioritizing, and it's going to inform a subsequent effort that we look forward to engaging in, which is about not just creating a federal priority or federal plan, but a national plan, taken from the best of public health around collective impact and trying to think of what we all can do together. Where should the feds lead? Where should we follow? Where are places that you all can inform us and we can do a better job of meeting you where you are so your data meets you where you are and it is actually available to make the kinds of decisions that make people more engaged patients, make communities stronger, and make us more prepared in the event of disaster and for every day. So I just want to thank the Robert Wood Johnson Foundation for including HHS in these conversations. It's really been a rich set of information. It's easy to get caught up in the Beltway, I'm going to tell you the truth, and getting out of there and coming to communities, doing listening sessions like these and other efforts we do is really a critical part of our work because this is about you all and the people that you serve and the people that you work with. So please be honest with us, please be open, please do one more thing and then I'm going to get off the stage, which is we do have a new draft strategic plan that just came out on Monday. It's open for public comment for 60 days. That means that everyone, all 318 million Americans, have a chance to weigh in, and we would encourage you to. Poor Seth, he's about to fall off his chair because I just... On the other hand, if you go to healthit.gov, you'll find the plan, take a look at it. It's a pretty easy read. Give us some sense about whether we're moving in the right direction, and these sessions are going to help us know that also, just because we're listening, and we're going to be looking forward to working with you all as we go forward. So again, thank you for letting us be here. Oh, and I can have time for one question, if there is one. Yes.
I'm a physician. I work for Robert St. Francis and lead the research effort there here in town. And one of the challenges is that I'm a electronic medical record survivor. And the reason that I state that is that I would like to get enough information about the patient that will allow me to individualize to the lifestyle of the human being, you know, to put a whole picture. However, I cannot put that information, my nurse cannot put it. But I observe many times that my patients have bracelets that measure the amount they walk. And they have put in their iPhones the information about what they eat and what they don't. I wonder if will be a way that all this information the individuals are collecting for their own purpose can be mixed or matched with the electronic medical records, obviously keeping care of their privacy. And then we can generate more than data, but process the data to generate information, both for the doctor and the patient.
It's a great question. It's exactly the kind of thing that we are working on. And there's a couple of nuances in what you said. So one of the things about collecting data is sometimes we think about collecting discrete data. So a structured way that we enter information or a drop-down box. On the other hand, one of the challenges that we have is, as a doctor, I can tell you the context of people's health and lives doesn't always fit nicely in a click box. So there's a narrative and some other information that we have to provide some balance between how much do we have discrete data and then what's the way that we have more qualitative or contextual information around. The other piece to what you're raising is how do we have data generated by people that can be either included in your electronic health record or included in their longitudinal record. And I'm just going to keep pushing y'all's brain about that because it could be that as your patient, I would send my data. I would have a feed once we work out things like data provenance, where did it come from, the privacy issues, et cetera. It could also be that I have another record that I let you look at when I come see you in the clinic and you send data to my record. It's a huge power shift. It's a technological shift. It's a privacy shift. It's a security shift. But it is there are folks thinking through, is that going to be one of the options that we have in the future? So I agree with you philosophically that the patient voice must be heard and a bigger picture of them must be a part of the whole record, but we also have to remember that there's more than just this discrete digital data. There's a narrative, and find a way to have a balance so we're painting the right picture of the people that we're here to serve. I think I'm done. I'm getting the hook. Sorry. Ask me later. Bye. Thank you all.
Thank you, Karen. It is an honor to have the ONC team here. They have been great partners in this effort, and they have been at every session, listening and learning and engaging in the discussion. So thank you, Karen, for being here. And I know you're busy. Now I'm going to welcome our speakers to the stage, and I invite our speakers to come up. And as they're coming up, we're going to take a moment to breathe, and I would like to see who's in the room. What organizations do we have in the room? What groups do we have in the room? Because the wonderful thing about this is there have been a lot of different people at the table, not the usual in the Beltway circle group, as Karen would say. Do we have any community organizations in the group today, in the audience today? Just raise your hand. Wonderful. Any public health agencies? Yes. Any foundations? Yeah. RWJF people, raise your hand. Any healthcare providers? Wow, that's great. Who am I missing? Businesses. Business leaders in the audience. Private sector. Did I miss anyone? There were some hands that didn't come out. Education. Anybody from transportation? Yes? Oh, wow. So thank you all for being here. Uh-oh, I missed one.
Cultural preservation.
Cultural preservation. And I think that's a special one for Charleston. I must admit, Charleston is one of my favorite places in the country, so I'm a little bit biased about being here and excited to be here today. I want to start by, I'm going to introduce each speaker just before they come to speak, but I'm very excited. One of the wonderful things about getting to be the moderator of this is I get to ask all these people some great questions. We're going to have each speaker speak. I'll introduce them before they speak, and then we'll have questions from the audience, and then we may ask the audience questions as well. And when I say audience, that's the audience here in the room and our audience that's listening online through the live stream. So I don't want to belabor any time, and I want us to get started. Our first speaker is going to be Dr. Ida Sim. Ida is a member of our Data for Health Advisory Committee, and she's a professor of medicine and co-director of biomedical informatics of the Clinical and Translational Science Institute at the University of California at San Francisco. And she's also, excitingly, the founder of mHealth. mHealth is a nonprofit that brings together clinicians, data scientists, developers, and designers to build tools and products that help doctors and patients collaborate and provide more personalized and preventive care. So, Ida.
Thank you. Good morning, everyone. This is my second trip to Charleston. I'm happy to be here, but I'm only here for not many hours. You know, we're awash in technology. 78% of office-based physicians now use an electronic health record, which is up from 18% in 2001. If you're an average American, you spend 11 hours a day on electronic media, maybe right now. Globally, more people have a mobile phone than have a toilet. And in just a few years, it's anticipated that 26 billion separate things, that would be your watch, maybe your car, your fridge, maybe by then we'd have mechanical hearts, they'd be on the internet. So there was a question about all these personal devices. Yes, that data is very exciting, and it will be flooding us, and it will complement the data that we get from the EHR to give a much more holistic view of our health. And of course, this is all very exciting. mHealth is a nonprofit that we founded, funded by Robert Wood Johnson, to break down the barriers for data to flow from these apps and devices so that you can bring it in and match it up with electronic health records and so forth. It's a very technical startup, very technological, so I'm not going to talk about it today, but if you're interested, certainly we can chat about it. But it is very exciting that we have all this data from these personal devices. But it brings to mind a common dictum we've all heard, right? Which is if you have a hammer, everything looks like a nail. And I wonder sometimes if in our conversations we talk as if all we have is technology. And when everything is technology, then everything looks like data. You know, data's everywhere. Larry Smarr is a computer scientist at the University of California, San Diego, and he's been tracking his own data. He was the first Uber tracker, one of the very first Uber trackers. And he went from tracking one data point about himself in the year 2000, so he tracked his weight. And you know, over a decade later now, he's collecting over 1 billion data points about himself. His weight, his lab values, his diet, his sleep, his physical activity, his whole genome, and more recently, the genome of the gut stats in his, of the bacteria in his gut, his microbiome. Larry is one of the most quantified people in human history, and soon we too may be as quantified as Larry is. So that brings up a question. If we have this tendency to think about technology and see everything like data, if we see everything as data, then what does health look like? I recently came across a new term that I hadn't heard of before, healthism, a lifestyle that prioritizes health and fitness above all else. And in a data-driven world, I think we might fall prey to maybe a modern variant of healthism, which is a lifestyle that prioritizes measurable health and fitness above all else. And I think it's easy to slip into, well, let's increase our step count. Let's monitor our calorie count. Let's track the number of minutes that we've acquired, of deep sleep that we've acquired, which probably isn't as much as we all need. And you know, we can do that, and it's, I think, very tempting to do that, but it could be very reductionist, right? Because then we are driven to prioritize what we can measure, which is driven by what technology enables us to measure. And that might allow technology then to define what health means for us. I think this is particularly a risk for these personal devices because they are so cool. And I think we don't quite know how to deal with that data yet. So I think a forum like this is very important for us to start thinking about how to not get seduced sort of by, you know, the cool technology, but to really focus on what that data is about, which is health and not healthism. But on the other hand, we have the World Health Organization's definition of health, which is quite expansive. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This sounds great. It sounds like a nirvana, but I would ask, is this our goal? Is this even a realistic policy goal? Because it's actually natural for us to have disease. We all are going to die. And so what really is health, and what really is it that we're trying to aim for? So we are here to hear your thoughts about data for health. As has been said before, this is the fifth in our last listening session. Particularly your thoughts about data around these personal devices. But actually the data part is easy. There will be new sensors that are being developed. Some of you may have heard about the Google contact lens that will be sensing your blood glucose level. I talked to the Google Lex folks just last week, and there are other sensors that they are developing that we don't know about. There are tattoos that you can are on your skin that will track your acid-base level, your sodium level. Obviously, there are sensors that measure your oxygen level. There are glasses, not Google Glass, but glasses that actually look in your eye to look at blink rate, look at dilation of your eyes. There's all kinds of sensors that are out there. So I don't think we need to worry about the technology part, what kind of data we want to get at, that we will get at. Really, the more important question is, what are we going to do with it? What is the health that we want? So I would reframe the data for health perhaps to say, what is the health that we want to improve? What does that look like? And what do we need along with data to improve that health? And I don't know what the blank is. It may be policy, it may be behavior change. I don't know, that's what we're here to listen for. But I think if we focus on the health part and the and part, then I think the data part will come into focus. So I'm really looking forward to the rest of today. Thank you very much.
Thank you, Ida. Next up is...
Go ahead.
Well, I have to tell them who you are so that they know. It's Dr. David Blumenthal. David's the president of the Commonwealth Fund, which is a national philanthropic organization that's engaged in independent research on health and social policy issues. But Dr. Blumenthal is also a former national coordinator for Health IT. And he's going to talk to us a little bit today about digital health. Thank you.
Thank you, Ivor. It's a pleasure to be here, pleasure to be in Charleston. Sorry I can't enjoy it more. I'm going to take off where Ida, I think, left off and talk a little bit about what we hear about. And this might be Ida's friend Larry. Maybe it'll be all of us at some point in the future. Maybe our children, for some of us who have children who we can imagine in this position. The question is, what is this about, and what does it get for us? And I think Ida began to pose that question. It's very clear that consumers are into the adoption of health data collection and the use of health data. So 46 million Americans now use our health or fitness apps, and that increased 18% in 2014 alone. Americans are wearing healthcare-related technology. 75% of consumers who use those technologies believe that they help their health. And as Ida mentioned, we are going to be seeing biosensors and monitoring devices of all kinds coming down the line. Now, we can be sure this is going to happen because venture capitalists are pouring money into this sector. They obviously see something in this area that has return on investment. In 2014, there was kind of a breakthrough on this investment type, as you can see. The extent to which people in Silicon Valley, Silicon Alley, Route 128, all those places began pouring money into mobile health just grew exponentially. Most of that data, most of that money is going into monitoring. That's that sort of lavender quarter that occupies 65% of this pie chart. And Ida raised the question of data for what? And I think monitoring is wonderful, but monitoring produces information that has to have a purpose. Otherwise, the cost of collecting it isn't justified. And the rest of this pie chart is in some sense the challenge we face. How do we use it for diagnosis? How do we use it for treatment? How do we use it for the maintenance of health? How do we use it to improve our healthcare system? I just want to raise one particular challenge that I think all of us should be concerned with. Some of us in this room have chronic conditions. Some of us have family members who have many chronic conditions. Maybe some of them are older. Maybe some of them are frail. In many ways, the big challenge that tends to get lost in the mobile health experience, which has been directed much more at young, fit people trying to maintain their health, which is great. But the part of the experience that has gotten lost is what are we going to do with the fraction of our population which is the victim of multiple chronic conditions, and in fact constitutes our high-need, high-cost populations. 5% of Americans cost over 50% of all we spend on health care. 10% account for 65% of spending. If we're going to get our healthcare system working right, and if we're going to take advantage of the data that we've been talking about, we have to find a way to involve this population in the mHealth revolution. That is a particular challenge, I can tell you, for people who care for those populations. There are general challenges as well that face the mHealth opportunity, the huge opportunity related to the data that is being generated in so many ways from both electronic health records and from the experience of individuals. We have to meld these data together with the data that are collected about our actual healthcare services experiences. Privacy and security is something we've just barely touched on, but it is a huge challenge for all health systems everywhere in the world, and believe me, globally, we are not unique. Everywhere in the world, countries are dealing with this question of how do we protect people's precious and sensitive healthcare data. We need to know, once we have data, that its use is valuable. And that, in fact, the recommendations that flow from its aggregation and analysis are useful to people and improve their health when acted upon. That gets us to this question of a buzzword that's come into our vocabulary recently called big data analytics. We are at the dawn of a new era with respect to analyzing data. Knowing that it's valid is great. Knowing that it's reliable is great. The algorithms that translate data into recommendations for daily action are basically non-existent right now, and they have to be tested. And then there are a number of us up here and in the room who are clinicians, have been clinicians. I spent 35 years as a primary care physician. Clinicians were overwhelmed in the paper world. They are going to be drowning in the mHealth world. So finding a way to help them help Americans stay healthy and improve their health is another challenge that we have to deal with. So thanks for your attention. I'm going to sit myself down and let the next person get introduced before he stands up.
Thank you, David. I think those are going to generate some really great questions. They're starting to come in already. Our next speaker is one of our local partners. This is Lisa Wear-Ellington. She's the president and CEO of South Carolina Business Coalition on Health, which is a multi-stakeholder business coalition. I love hearing from businesses about their perspective on health. It's great. The members of this coalition include BMW, GE, Boeing, and she has a great background and a really rich background in healthcare delivery. And she's built a hospital-owned managed care company from the ground up and has extensive experience as an insurance consultant. And she's going to talk to us a bit about data and the role of the business community.
Wonderful.
Thank you, Lisa.
Thank you. Well, if you can tell by the accent, I am the local person here today. But I don't sound like Paula Dean. I always compare myself to that. So data decisions for employers in healthcare, does data drive those decisions? Do they have the data they need to make the decisions? Let's talk about that a little bit. I am the president of the South Carolina Business Coalition on Health, and you heard some of our terrific members. There are many other great members in the state, and DHHS has recently joined our membership. But I'm speaking really from 30 years of experience in working with employers trying to find solutions for the issues they have around healthcare cost, quality, and patient experience. So just to frame up my remarks today, our 4 central goals at the coalition are improved healthcare effectiveness and efficiency, greater consumer responsibility, improved economic competitiveness, and healthier people. And healthcare costs are so important as we try to retain and attract businesses to South Carolina. The cost of healthcare here is higher sometimes than they thought it might be coming in, or maybe the systems aren't working as well as they should. So it's important for all of us to consider what the employers need. The first issue is really determining what data is critical. Is unit price of care the problem we need to solve? Is that the problem, and are there solutions around that? Well, let's talk about that for just a minute, because throughout my career, what we've looked at is the fee-for-service, the fee schedules. Drive down the fee schedules. It's sort of a merry-go-round of fee schedule negotiations year after year. But we've learned over these years that that is really not the problem. It is certainly a cost factor, but the main problem is how we utilize the medical system. Some examples of that are how patients access the system, what is the site of care. There are so many sites now that there used to not even be in existence. How do patients move through the system? You go to your primary care doctor, you get sent to a specialist. Does that information get back? You may need a surgery. Combining all that information together so you can look at the whole person and their episode of care is vital. And coordination of care between providers as well. What data is needed to improve the healthcare system? And this is certainly a short list, and if any of you have ideas that you would like me to mention while I'm up here, please shout them out. There are current holes in data capture. Right now, most employers depend on claims data. But claims data, for one thing, is after the fact, and for another thing, it certainly doesn't give the complete snapshot of everything that's been done. Data access is another issue, and my employers are all self-funded, but even they struggle to get their data sometimes. And when they do receive the data, if it's just a complete data feed, it's not necessarily actionable. They may not have analysts on staff that can sort through the data and see what's important and what isn't. So what we have here really is a lack of a consolidated analytical approach. What data is, or maybe not, is not available that could affect that individual? Well, we talked about claims data. Some employers carve out pharmacies, so you might have a separate PBM that has data. Most of my members have on-site clinics, and they do health risk assessments and biometric testing, so there's that grouping of data. There's the data that comes from the provider's office, the clinical data, which is certainly not fed back into an employer. And absence data is also very important because employers nowadays are tracking not only how the wellness programs affect the medical claims costs, but also how it affects disability claims as well. Who has other ideas? We've learned some today. I didn't know we were going to have to do tattoo and contact lens data as well to include in. Have I missed anything? Does anybody have any thoughts you'd like to add? Pretty much covered it? So what is the wish list? Well, I think the wish list is this, and let me tell you why. I want to back up just to kind of lead you through a thought around how big data and data that's down to the patient-specific level affects employers. HR folks are trying to put together benefit packages that are good for the employee, steering them to quality physicians and so forth and so on. So say that an employer looks at their diabetic population, and maybe they want to have incentives around the diabetic population so that those folks will be compliant and perhaps to get their A1C under 7, for example, and I'm not clinical. But is that captured in the claims data? These folks may go out to their physician's office to get their readings done. Some people now go to retail clinics because they're advertising that they do chronic disease management as well, so there may be an A1C sitting out there in a retail environment. There's pharmacy data that's not connected to the claims data necessarily, or they may have this A1C done at the on-site clinic. But every year, when you try to look at that incentive money and how to build your program and how to make it the most cost-effective, high-quality program you can possibly have, how do you do that with all these disparate data sources? So the wish list, at least in my opinion, is the ability to combine data into a common database at the state or community level. And we heard earlier this morning there is some data that's being combined that way, but I don't believe the private sector is involved in that. And I think if we could move to that, an all-payer database would really be a terrific addition, I think, for the entire community. And I hope there's discussion around that today. Price transparency is another issue that's always at the forefront of the employers' and the employees' minds. More and more employers are going to high deductible health plans, so it's imperative that the employee be able to make good decisions based on cost, but that cost isn't really available to them. I often say, and I have great friends in the hospital business, but it's the one place that you go for a service, you go in, you have it done, you don't know how much it costs, you go home, it may work, it may not, you may have problems, but at the end you get a mystery bill. And that's something we really need to work on. It's very important. The employers want provider payment based on outcomes. What does that look like? How do you capture it, and how do you make that decision, and how do you make payments to that provider based on value? And we're looking for data analytics that produce a pathway to potential solutions because HR people, I have such respect for them. They really are in charge of these tremendous health plans. You've got employees that may or may not want to cooperate in certain things. It's quite a task, and the more we can help them with actionable data, the better it is. So I'll be around afterwards to answer questions, and I'm going to turn it over to the next speaker.
Thank you, thank you. And our final speaker is Bernie Mazyck, and he's the president and CEO of South Carolina Association for Community Economic Development. And he's really been involved in fostering the growth of community development movement for over the last 14 years. And under his leadership, the number of community development organizations in the state has grown from 4 to 70, with one being in every county in South Carolina. And he's going to talk to us a little bit about the role of data in community development. Thank you so much.
Well, good morning.
Good morning.
Now, see, I come from a cultural heritage that's called call and response. So when I say good morning, there you go. First of all, I'd like to welcome you to Charleston on behalf of my board and colleagues, all who are visiting from Charleston and from outside South Carolina. Welcome. We're delighted to have you here and just honored that you would bring this listening session to Charleston. We thank you and come back as much as possible. Community economic development, and as I was first approached about this, and I said, okay, you're going to talk about data, you're going to talk about health, and what role does community economic development have in all this? And after hearing my colleagues on the panel, I hope what we'll talk about and what I'll share with you is how the data that we're talking about in health actually has some application on the ground. So in community economic development, those who are not aware, this is a 40, 50-plus-year-old strategy that's about helping to improve the economic and well-being within low-wealth, poor communities throughout the country. This is a national strategy that's been around for over 50 years. And in South Carolina, that strategy has been in place for about 20. We've been developing for about 20 years. And so it's embodied in this organization called the South Carolina Association for Community Economic Development, where we're working throughout the state to try to create the good quality of life for residents within communities. Now, traditionally, that body of work is focused on affordable housing, maybe job creation, workforce development, entrepreneurial development. But now in this paradigm, we see an exciting opportunity for how that quality of life includes health and the role that we can play in that. So the association itself, which is the South Carolina Association of Community Economic Development, we and our partners are about creating a good quality of life for low wealth and poor residents throughout the state, and we do that through something we call community economic development. And what we do at the association is work to build the capacity of local organizations to be able to address issues of quality of life, economic prosperity within local communities using local assets and packaging those assets in such a way that they can create a good quality of life for the residents in those communities. Fortunately, we have over 70 organizations. 33 of them are certified by the South Carolina Department of Commerce, and those certified organizations reach every county in South Carolina. So we have a footprint that can go about the business of addressing issues in every community. Now, whether we are totally effective in every county, I'd say honestly no, but we're building that capacity so that whatever the issues that might be to raise the quality of life in every community, we have a network and an infrastructure that is capable of doing that. So we listen to our members. We engage our members. Our members come to us and share with us strategies and indicators that are affecting what's going on in their communities. And some have noticed that the health disparities also affect the wealth of their community and their families. If you can imagine a person of low and moderate means that have health issues and how much of their income they have to direct at those health issues, prescriptions, visits to the doctor, and so forth. And so as our members came to us and talked about and started noticing data around diabetes, hypertension, and the other issues that affect their clients' health and affect their wealth and ability to build wealth, we started looking at how that can be addressed. And one way that we also started putting data on the table is as we started indicating nutrition. And they started focusing on food deserts, where individuals are a mile to 5 miles away from the nearest full grocery store or healthy food marketplace. And as they started layering those data sets and mapping them, they began to see some correlation and started thinking about strategies. Now, we are not, at the association, is not the body of all knowledge. We derive our knowledge from our members. Here we have in our audience South Carolina Community Loan Fund, who's the CEO, is Michelle Mapp. And they brought this information forward and really started working with us and our members to start talking about how we can affect change in this area, how we may be able to build an infrastructure that can affect this issue so that the individuals and families within local communities can start affecting their own health condition, thereby lowering their expenditures on health issues and really start building their own individual and family wealth. And so they brought forward an idea of a network of healthy food markets, healthy food hubs, closer to where the communities are. The other thing that we identified is our state is a relatively rural state, so we have lots of land here. And a lot of that land is not being productive. We also have a culture and a tradition here of agriculture, but it's not being maximized. So we're starting to work with our members, work with individual landowners so that they can start and begin to use that land to produce healthy food and make that food product available closer to the communities that need them. One such example is a healthy food market place that we and others have invested in Spartanburg, South Carolina, that is located in a food desert and now is making available that product closer to the community that needs it. Thereby, they can begin some of the patterns and practices of healthy nutrition, thereby lowering the impact of diabetes, hypertension, and so forth, and thereby keeping some of that wealth within the community, within the family, so they can grow their own individual wealth. We have a similar entity here in Charleston called Grow Food Carolina. And these mechanisms are here to affect not only the health of the family and the community, but the wealth of the family and the community. So I look forward to exploring this further with you.
Thank you. We've had some great opportunities with our speakers today, and I just lost my screen, but I wanted to talk a little bit about what we heard today. It's really interesting. We started out with Ida talking about the fact that data is there, but what we really need to talk about is the health and what it's for, and then the data will come to serve the needs, and I think that's an important message. And then we talked a little bit more about how we can use digital health and how it's growing, but then one of the things I love about these sessions is this opportunity to then talk about businesses where we don't often have that conversation, particularly in the academic world where we're going, what's the need of the private sector in terms of data, and how can the private sector help us in driving what information we're asking for from people? And then the ability to, and then when you get to the community level, the ability to use data for community building and community organization and community collaboration. I'm going to open it up to the audience, but then starting out with asking the group, where do you see some of these intersections in the different areas that you're talking about? Particularly thinking about me as a provider, we're trying to talk away from the health system, but as a provider, how can I think about that information in a way that's going to be useful for the patient and family from your various perspectives?
I would start. I'm a primary care physician, and I wear many hats. I work in clinical research at UCSF. I run a nonprofit tech startup. I'm a primary care physician. And my life is kind of compartmentalized. You know, when I go into the clinic and I close the door of my patient, I don't have time to think about research, and I certainly don't have time to think about any data that might be coming from, you know, all these devices. And I think that's a very natural and understandable reaction from us as clinicians with the time pressure that we have. On the other hand, I talk a lot to patients, and patients who are very active in digital health, and they're quite frustrated. They collect all this data that they think is of value, and they take it to the doctor, and the doctor goes, ugh, right? So I think part of the problem is we're not being collaborative. Mm-hmm. We're not talking together about what we're trying to do, and then deciding what the data is that will help us to get at. And so I think we need to start having that conversation and being collaborative about the data prescription, which is what I call it, and then the technology needs to support the clinician and the patient deciding what problem we're trying to address and what data we want, and then making it really easy to get that data. Which means for me as a clinician, I don't want to know whether you have a Fitbit or a Jawbone or the Fitbit Flex or the other Fitbit. I don't want to know any of that. You know, when I order a potassium level, I don't know whether it's from a GE machine or a Siemens machine or whatever, right? I just want that data to be there. I want it to be trustworthy. I want it to be the kind of data that I can have clinical action on. I want it to be data that's meaningful to my patient, and I want that data to help me have a conversation with my patient. That's what I need it for. So in Open mHealth, we are building that. We're building the technical infrastructure to allow us to be device agnostic about how we get data. We're trying to build an infrastructure that allows us to focus on the data. And we have just developed a tool called Link, L-I-N-Q, that actually allows patients and clinicians to start having that conversation and that dialogue. So again, it's sort of get away from the data. Let's talk about what we really need and what we're really using the data to support. So I think that the opportunities are wide and very, very exciting for that.
It's a great question. I think that we have to recognize where we are historically in this process of collecting data, mobilizing it, organizing it, and then acting on it. And we are just at the point of understanding the potential of collecting it. We are going to have to build the capabilities to collect it. Then we're going to have to build the capabilities to merge it together. We're going to have to build the capabilities to understand what the data means. You know, I wear a mobile device like everyone else. I think half the time it's wrong. And I don't really want anyone to use that data to prescribe to me or tell me what to do. I think it's kind of interesting, but I don't trust it. And I think until we get those mobile data sources in a state where we understand what it really is and means and how much we can trust it, we have to be careful with it. Then once we've got that reliability and validity problem solved, then we have to say, okay, I know what my heart rate is all day long. What does that mean? What should I do with that information? What should I do with it individually? What can my family do with it? What should my phys ed instructor do with it? What should my clinician do with it? So these are all steps on the way toward this ecosystem of data that we have to get to. There's an enormous technical research agenda that I think we have to get past. This is not to put a cold blanket, a wet blanket on all this, but I do think we need to be humble in the presence of all these capabilities that we're developing and understand what we can and can't expect them to provide for us in the short term. I also want to bring us back to this population that is in danger, I think, of being left out of this revolution. These are the people who are really sick, the people who desperately need to have their information monitored and included in the care process, and who are in some ways least able to participate often in that process. And they are a goldmine of societal opportunity for safety improvement, quality improvement, health improvement, and they constitute a specific and difficult challenge within this general challenge that I've elaborated.
And I think that brings up a question that we're getting online from at Emily Ross and Shelley Quinga. It's really about the fact that a lot of what we're getting in terms of the technology is focused on the young and the fit. And what about people with chronic conditions who, with high need and high cost, particularly the elderly? And though we know many elderly are using technology and innovation, what about those people who don't have access to technology, who don't touch the system, and how we can reach those folks?
I was just going to comment from my coalition perspective. Since we do have all these data sources, what we're considering within our group, because employers are very siloed, you know, they just look at their own data, but there's tremendous value in combining data and benchmarking and those sorts of things. So it's something we're considering doing within our organization, creating a data repository that would bring in some of these data pieces, and we could have overlay it with analytics so we could make some good decisions. And we also want to work with the public sector on that as well, and potentially, as I had said earlier, having some combined data capabilities.
And I would say that it's important that how data is packaged in such a way that it can be consumed by a variety of sectors. Because if you look at the constituents that we work with, which are folk in communities, sometimes community organizations, but of course our community development corporations, community development financial institutions, they're working with consumers on the ground. We might think that, okay, there's no way for them to absorb and consume this data for their well-being. But what we're seeing is if the data is packaged in such a way that it can be absorbed, there can be broad applications, especially as it relates to health. Because one of the greatest challenges in a lot of our communities is the health condition and the outlay of resources that's needed to maintain that. So just like with the food hub strategies, there's so many other ways to apply that data, but it's so important to package that data so that a variety of stakeholders can absorb it and apply it for their own strategies.
I want to sort of pull out on that. We had, during the listening session in San Francisco, obviously we had a lot of technology companies, and particularly working with underserved populations, and populations that are often not connected with sort of the most recent technology, in encouraging sort of people to work with the community and engaging the community, not just sort of in giving them information, but working with them in the development of things that gather that information. And I would really love to hear your perspective on ideas and thoughts about how to engage the community to be a partner, for people to engage better in working with the community, be a partner in gathering there's a question that we had in one of the sessions that said, getting away from what's the matter to asking what matters. Mm-hmm. And that would be sort of, I'd love to hear your thoughts on that.
Well, it's interesting because you're saying also use the community as a source of data, to draw data. And some of that method of drawing data may not fit into our current models of how you collect data. Sometimes it's through stories and sitting down and listening to what people are saying, what stories they're sharing, and you will see some patterns emerging. What was said earlier, for example, that you now have more people with cell phones and iPhones than toilets. And that's true. So use that mechanism to communicate and to identify what's happening at the community level, and then let's use all of our great brain trust at this level to take that data and say, okay, what's really happening here? Let's understand what's happening here. And then to connect with those institutions that can affect what's happening in these communities through health. Someone said earlier that they'd want to, who should they work with? Who should they collaborate with? My opinion is everyone. Everyone has a role to play. A new initiative we're launching is with churches. Churches in marginalized communities are a tremendous resource if they can be tapped and accessed in the right way.
Thank you. One of the things I love about this discussion is we're almost getting back to the grassroots efforts of what we were doing before, and talking about how do we merge the new with some of the things that we've always done in the old. I want to open up the floor for questions. And there are folks with microphones standing around. I probably should have given them a little bit more warning while they're while they're heading to the first person. I'll ask a question from Christine on the live stream. And the question is, what strategies will we put into place to protect the privacy and autonomy of the individuals and families whose data we want to use? So this is a big question about the value of protecting families and then the value of that data to them in when we're using that data. So, anybody want to?
I think it's a matter of having trusted sources. I don't know whether it's appropriate to collect individual data. We were talking earlier about, with all the availability of mobile devices, giving the permission to access maybe Facebook pages so you can actually see the behavior and activities that people are involved with. But maybe not collecting data at that level, but having trusted sources that can relay that data to maybe a church, maybe a community organization, and then have them with all the availability and ability for safeguards to protect that data. So it's just going to be about having trusted sources and having a way of safeguarding.
So we desperately need a public dialogue about what privacy and security means in the age of mobile health and data mobilization. I think the American people will come to terms with the idea that there are huge benefits from having large amounts of data about them accessible to them and accessible to their caretakers, in some cases, but not all cases, to family members, and to researchers who want to, and public health officials who want to improve health and protect health. They have to make that judgment, though, in light of the benefits that they realize individually. And that's the trade-off that we're going to be discussing as a nation. What are the benefits? What are the risks? And I think one of the critical elements in this is going to be people's sense that they have control and that they can make the decisions about what data is shared and what data is not shared. And that trust is going to have to be part of the discussion. We shouldn't assume that people are going to be willing to have their data available, but I think they will be if educated and the discussion proceeds. So I think openness and a broad conversation, we are not having that conversation right now. It's really not part of the discussion. One of the things that is an unfortunate fact is that we don't have public policies and legal frameworks that penalize people who abuse healthcare data the way we do, for example, penalize people who abuse the U.S. mail. You're not allowed to, it's a federal crime to access someone's mail without their consent. It's not a federal crime to access their data if it's not part of a medical record, a formal medical record. So we have a long way to go in terms of creating that trust framework, but it begins with a conversation that I think we need to start having.
I just want to second that we do need a conversation. I think also the notion of data citizenship, that there are, you have rights to your data. I think in some sense there's a responsibility with your data as well, because how we learn about health, how we optimize the health of our communities, comes from the data that is ours personally. And when we participate in a civic entity, whether it's your family, your community, your state, I think there's a bit of responsibility about our data, certainly anonymized and protected, but we're part of a polity, we're part of a common effort. So I think taking the discussion of data away from how do I be safe, what is privacy, what is security to me, and really maybe reframing it again, think what is our participation in this data citizenship? It's going to be critical as we move forward, not just for health data, but for all this other data together. What is our relationship? What is our duty to ourselves and to each other? And from there, I think we'll flow through all these discussions that we've been talking about.
Thank you. I think we have,
yes.
Start here.
Right.
These 4 presentations have reinforced to me one of the biggest challenges and concern. Most of the data we have available, and my fear is that most of the data that will be supported financially is very healthcare centric, very clinically and medically focused. And Lisa, your comment about the fact we have employers that moved to South Carolina that didn't realize that maybe their healthcare costs were going to be higher than they were. What if where the person lived might be the most important factor? And yet, we don't really look at data at that level. Bernie, I appreciate the fact that you bring up things like food deserts. And so we look at this clinical data may be important, but at the end of the day, for that diabetic patient, where they live, if they live in a food desert, the clinical system alone can't fix that. And so that's 20% of what affects health status and health outcomes. But I hear very little discussion other than maybe tracking individual behavior and measures with that of what are we going to do to invest in actually getting data at the population level about health. And so for your employers, I think right now they're still looking at healthcare-centric data when it may be in many cases they don't know where their employees live as such, might be the biggest factor. And
it's
so
a great point.
Yeah, I guess challenge and question how we're going to go about doing that.
Well, I think that speaks to the need for the data to be available to a broad cross-section of players, because the clinician, of course, is not going to be able to affect where someone lives, but there are institutions where that patient lives that may be able to affect behavior and what's available to them.
And could work with the clinical system.
Exactly.
We have about community health workers that are non-clinical people. That alone will make a huge difference in readmissions, and yet because the data is healthcare centric, it's hard to get the hospital systems to realize the value of working with those community-based organizations.
Thank you. We have a question in the back.
My name is Scott Moore. I'm actually a statistician. Hopefully there's a few statistics or data scientist folks here in the room. I think that what I've heard here just in my brief visit is trust. Trust of the data is a big issue. And then trying to figure out what matters is also a problem. And I think what we're not doing in today's world is we're not experimenting with the data. I'll be the first one to say I really don't trust the data at all, because I'm not sure that the data is actually going to solve the problem. And the way to do that is actually to experiment. And the great thing about today is that technology has gotten to the point where experiments are very, very cost effective, and you can actually figure out whether or not the data and the process that you're collecting is actually going to solve the problem you want to try to solve. So I'm advocating for really understanding the data in an experimental format and then applying that to a hypothesis or a solution that you're trying to incorporate into the community.
I think we have a question here. And we have a mic here.
So previous to the conversation, the interesting thing that struck me is, we're focusing on how many individuals have cell phones, more than toilets, but through using other data that the financial agencies have, we know who don't have toilets. We know who those people are, and maybe that's a better group to focus on because we have that data, but our conversations this morning about let's get all the cell phone data, and it's what's in the community as well as what do the patients want. Our industry is the worst of all industries. I mean, BMW would never build a car without talking to people who are going to buy the cars. And we're having conversations without the patients way too many times.
I think one of the key things in this discussion, and I think one of the things that we want to really draw out, is we've talked a lot about health care and the health care system, but we really want to talk about health as well, because there are many, many people who don't touch the health care system, but the people in this room serve those people all the time. And how can we work to serve those people who may not necessarily be touching a healthcare system and don't have an electronic medical record, or it's way, way outdated, or doesn't come close to telling the story of their health? How do we work with that? How do we do that as well?
So I'm an emergency physician at the Medical University, and we have a ton of data. We have a very robust health information exchange that encompasses every emergency department in our community. So we have health information on every single patient in our entire community since 2008. Patients expect that we have that information. They are shocked when we don't. first of all. Second of all, big data is very expensive. We have a ton of data. I can tell you where patients live that use the ED 5 or greater times in a year. I can tell you pretty much anything you want to know. I can tell the federal payers that their patients are the ones that use emergency departments much more than self-pay or than Blue Cross. Our problem is data is expensive. Collecting, managing, storing, manipulating data is expensive. I work more than 50% clinically. I'm a medical director. We have lots of other responsibilities. Partnering with the community is difficult. I'm not aware of good venues. I would think BMW and all these other agencies would love to partner with us. We reduce redundant testing, we reduce cost, we improve efficiency with this health information exchange that we have, but I'm not sure we're going to be around in 2 years. Sustainability is very difficult. How do we get CMS and Medicaid to come to the table and say, you're saving us a lot of money? How do we get the businesses to come and say, we want to partner with you because by having you in our state, you're reducing cost, you're improving efficiency, you're improving quality, and you're improving health of our population. So as a boots-on-the-ground clinician, I have tons of data for you. I don't have money to pay statisticians to help me with the data. We've begged, borrowed, and stealed. Thank you, Duke Endowment, for getting us going and helping us get some health economists to help us with the data, but we're out of money. It's very difficult to sustain what we have, but I think every person in this room knows that it's the right thing to do. How do we keep it going? And how do we partner with the community, I'm an academic physician. How do we partner with the rest of you and get you to give us money because it's the right thing to do? Sorry.
Yeah. So we have about 5 minutes. Hopefully I can get a couple of questions in.
So comment, we talk a lot about privacy. And I could not avoid thinking about the other day. I got my iPhone, and I got 12 apps that they said that I needed to read this 20 to 100 pages policy that they have for privacy. And I decided, I signed agree. I didn't read 12 times 100 pages because I wanted this very cool game that, everybody told me was amazing. So I gave them no idea what. I have no idea what access I gave them voluntarily. Why? Because I have a value proposition. The value was I wanted a cool game. Now if we can manage to articulate a value proposition to those people sharing the data at the individual level rather than the collective level, I think that the collected data would not be so difficult. And also, is that will oblige us to do what is the most important, is to process the data, to change data into information that will have value. Otherwise, I don't think that we overemphasizing in the problems, but not in the reasons that people have to participate.
Thank you. And we talk a lot about actionable data and actionable information. I think we have we can take one more question. Right here in front.
Good morning. My name is Clifford Fulmore, South Carolina, PTA. This is from a personal perspective. I'm listening to the conversation, and I want to give my personal story from a patient's perspective, and that is 7 years ago, I was diagnosed with end-stage renal failure. My wife did donate a kidney to me, and I did get that from MUSC, and I got to get that plug for MUSC. But yet and still, I do have the access to my records through MUSC, and we was talking about collecting this data, and then why does it matter? What do we do with it? Okay, so when Clifford goes to and access my record, and I look at my creatinine level, and I look at my potassium, and I look at all these things, and I say to myself, what does it mean to me as a patient? Okay, and when I saw it up there, and we talked about it, about monitoring and all these other activities, but then I say, okay, so what am I supposed to do with this data now that I have it? That, so therefore, as we continue the discussion, what I'm asking for is the experts in the rooms to please think about from the patient side, and that is, as we collect this data, do we also get a process where we also have in place where we're now going to educate our patients on what to do with that data?
Thank you. I think that's a perfect way to wrap up the session, because that's the whole point of why we're here. We're here to serve, and we're here to use this information and this data to improve the health of the communities that we serve and the communities that we live in.